Okay, circulatory system. Okay, on the circulatory system, we'll go ahead and get started on that. We started on it last week, if you recall. Just gave you some introductory aspects of it. There are 5 general classes of blood vessels in the cardiovascular system. Arteries, the small arterial branches, the arterioles, each of which, as you see, the diameter of the blood vessels will progressively get smaller and smaller as we get through the arterial circulation. From the arterioles, blood basically moves into capillaries. It's at the level of the capillaries that you see an exchange between oxygen and CO2, typically at an end organ level. Then the diffusion, once that occurs, the deoxygenated blood, or blood with a higher concentration of CO2, will move into the venous capillaries from the arterial capillaries, and then go in progressive diameter back to the heart, where it eventually will hit either the superior or inferior vena cava and enter back into the heart, where it will go through the pulmonary circuitry and become oxygenated again, enter into the left ventricle eventually, and get back to systemic circulation, and it starts over again. Capillaries, from the arterioles moves blood. Capillaries, of diffusion occurs at the level between blood and interstitial fluid. Branches decrease in diameter, as I said earlier. Venules, from capillaries, blood enters into small venules, where it will unite to form larger veins that return blood to the heart. In the circulation of the heart, 2 major arteries connected to the heart associated with each ventricle. Blood leaves the heart in the pulmonary trunk, which originates at the right ventricle, as you already know, and then the aorta, which originates at the left ventricle. Arteries leaving the heart, the pulmonary arteries, which branch to the pulmonary trunk and carry blood to the lungs, and then the systemic arteries that branch from the aorta and distribute blood to all the other organs in the systemic circuitry. Within these organs, further branching will occur, as I've already alluded to, several hundred millions of tiny arterioles that will provide blood to more than 10 billion capillaries. These capillaries, barely the diameter of a single red blood cell. That's why blood vessels and red blood cells have to be extremely flexible. That's why even the slightest amount of disease in the capillary system can lead to significant problems, because easily obstructions can occur when vessels are that small. If all the capillaries in the bodies were placed end to end, it will circle the globe in combined length of about 25,000 miles. That's a lot of blood vessels. Capillary diffusion. Vital function in the cardiovascular system depends entirely upon the capillary network. All the chemical and gaseous exchanges that occurs in the circulatory system occurs because of the exchange that takes place in the capillary system. All the chemical gaseous exchanges at any end organ level, there has to be an exchange of CO2, O2, nutrients have to get there, glucose, proteins, carbohydrates, lipids. Anything that's involved in the cell membrane, epithelial tissue, whatever, relies on the ability of the capillaries, the heart, to be able to supply blood to the level of the organs, where the capillaries would be involved in the exchange of these nutrients from various tissue structures. Diffusion occurs very rapidly. The distance involved is very small, because the vessels have very thin interfaces with the other vessels and tissue structures that are located there. Homeostasis, a concept that you're well versed with now. Homeostatic mechanisms operating at a local, regional, systemic level adjust blood flow through the capillaries to meet the demand of the peripheral tissues. Blood flow requires vessels that are resilient enough to withstand changes in pressure, flexible enough to move with underlying tissues and organs, yet tough enough to remain open and operational under all physiological circumstances. Artery, veins, capillaries different in function. Their functional differences, as always, involve particular structural adaptations. Accordingly, each type of blood vessel exhibits distinctive anatomical features, which we'll go over just a bit. Modifications are based upon the specific locations. These are the vessels. I showed you this last week, where you need to be able to identify the different levels or different layers, structures inside the blood vessels. There is the tunica externa, which is the external, obviously, portion of the vessel. The more central located smooth muscle, referred to as the tunica media, learn how to spell it right now. The tunica intima, which is the most inner layer of the vessel itself. It has direct contact with the blood flow and fluids in the inner portion of the vessel. Also appreciate the lumen of the vessel, lumen of the vein. Now notice the big difference that you see between the vein and the artery, the thickness of the muscle wall. Notice the thick tunica media that you see in the artery. Notice how thin the muscle layer is here of the vein. Notice how collapsible you see the wall of the vein is. Very thin muscle, so not under a lot of pressure, and so this vessel has a tendency to collapse very easily, whereas arteries have a thick muscle wall, a lot of elastic fiber, and they stay open quite well. I thought there was something point to. Yeah, elastic fibers. Notice the elastic fibers that we see here. Need to appreciate that inside that muscle wall. Elastic fibers. Again, blood vessels are under a tremendous amount of stress. So when the heart beats blood, they got to stretch a little bit, but then they got to relax to maintain the pressure. Stretch a little bit, relax under pressure. Do that one more time. Stretch a little bit, then relax under pressure. Okay, so keep that in mind. You don't see that with the veins. The veins have smooth muscle, yes, a little bit. They also have an endothelial layer, not epithelial layer. Don't mess that up on the test. It tells you that's a test question. Endothelial, not epithelial, and epithelial will be wrong, not misspelled. Endothelial layer. There's a tunica intima, there's a tunica media, and a tunica externa. The walls of the arteries and the veins contain three distinct layers: tunica intima, tunica media, tunica externa. Again, learn how to spell those. Tunica intima or tunica interna. The tunica intima, again, innermost layer includes endothelial lining. Arteries in the outer region of the tunica intima contain thick layers of elastic fibers called internal elastic membrane. Tunica media, middle layer, contains the concentric sheets of smooth muscle, collagen fibers as well, commonly thickness the wall in small arteries. The tunica media is separated from the surrounding tunica externa by a thin band of elastic fibers called external elastic membrane. Then the smooth muscle cells of the tunica media encircle the endothelial lining of the lumen of the blood vessels. When these smooth muscles contract, vessels decrease in diameter. When they relax, the diameter increases. Large arterioles also contain layers of longitudinal arranged smooth muscle. Tunica externa, tunica adventitia, is the outermost layer of the blood vessel and forms connective tissue sheet. In arteries, this layer contains collagen fibers with scattered bands of elastic fibers. In veins, it is generally thicker than the tunica media, contains a network of elastic fibers and bundles of smooth muscle. Connective tissue fibers of the tunica externa typically blend to those in adjacent tissue, and it stabilizes and anchors the blood vessels. The blood vessels can't be free to just kind of flop over everything. There has to be connective tissue that kind of holds them in position, holds them in place for them to be able to function. Layer walls give arteries and veins considerable strength. Muscular and elastic components also permit control and alterations in the diameter of blood vessel and blood volume and the changes. Now, blood vessels need blood too. Vasa, vasorum, need to learn that, know how to spell it. Vaso, vasorum. The walls of arteries and veins are too thick to allow diffusion between bloodstream and surrounding tissue, even between blood and the tissue of the vessel itself. For this reason, the walls of large blood vessels contain small arteries and veins that supply smooth muscle cells and fibroblasts of the tunica media and the tunica externa. These vessels are called vasorum. Okay? Now, small blood vessels like capillaries, do they have vasorum? No, they don't. How do they get blood supply? Through diffusion, like I said up here above. The walls and arteries and veins are too thick to allow diffusion between the bloodstream, but in the smaller vessels that aren't too thick, they can get oxygen supply, they can get nutrients through the process of diffusion. This is only for the big blood vessels, okay, like the aorta itself, thoracic aorta, abdominal aorta. Differences between arteries and veins need to be able to compare and contrast. Arteries and veins servicing the same area typically will lie side by side. So in a lot of the anatomical structures, if you can recognize the artery, you can recognize the vein. Artery is usually highlighted in red, the vein usually highlighted in blue. No, I'm just kidding. Then the lymphatic vessels, they're usually highlighted in green. This is important for Sarah since she has more coloring pencils than anybody I know in this world. But anyway, arteries are thicker, walls of the arteries are thicker than those of veins. Tunica media, an artery, contains more small muscles and elastic fibers than does the veins. These contractile elastic components resist pressure changes generated by the heart as it forces blood through the circuitry. Walls of the artery can constrict. When it's not opposed by blood pressure, the elastic fibers in the arteries of the walls will recoil, which will constrict the lumen. So again, that process of elastic fibers. Okay, so now in the cross-sectional picture that I'm about to show you, you'll see the familiarity and the corresponding differences between arteries and veins. Because the walls of the arteries are relatively thick and strong, they retain their circular shape in section, whereas veins tend to collapse. I thought a picture was following that. But from the earlier picture, I think I showed you how the vein has a thinner muscular wall. The vein has a tendency to collapse because it doesn't have as much muscle, doesn't have as much elastic fiber as you see in the arteries. The endothelial lining of the artery cannot contract. So then when the artery constricts, the endothelium is thrown into folds, and it gives the arterial sections more relatively a pleated appearance. It kind of seems to be kind of folded on top of itself. The lining of the veins actually lack that fold because, again, you don't see as much elastic fibers. Arteries are more resilient. When they're stretched, they keep their shape. They elongate. When they release, they snap back into position. Small veins cannot tolerate as much distortion without collapsing or tearing. Veins have valves. They have one-way valves. Similar valvular process as we saw in the aorta. The pulmonary vessels have valves. Similarly, you'll see veins have valves. They're one-way valves. They only allow blood to go up, so the valves will open up to allow blood to pass, but as blood starts to fall back down due to gravity, the valve slaps shut. Okay, so this is one of the other differences that you see and maintain in vessels as well. This illustration is out of your textbook, again showing you diameter, large veins, medium-sized veins, smaller veins, capillary system, same here, arterioles, smaller vessels, arteries, medium muscular arteries, going up to larger vessel of the abdominal, thoracic, and main aorta. And this breaks it down to you as well, telling you about the elastic layer, endothelium, then the tunica intima, which composes those two particular areas or structures, then the tunica media and tunica externa. This is the vessel as a whole. So very important to appreciate. If you can illustrate these objects here on this slide, then you'll be well ahead of the game. You will get a cross-sectional picture, either an illustration or that original picture that I showed you before that shows the different layers of the blood vessel. Contractility of arteries, contractility of arterial walls gives them the ability to change in diameter actively, primarily under the control of sympathetic division of the autonomic nervous system. Now again, I know we have not done the nervous system, but when we say under the control of the sympathetic division of the nervous system, sympathetic division of the autonomic nervous system is the fight or flight response. If you're in a bad situation, either you're going to stand your ground or you're going to fight, which means you need all the adrenaline and all the energy you need. Blood vessels in certain areas need to dilate to provide extra blood flow, extra oxygen supply, because the muscles have to get ready, or you're going to run. If you're going to run, then you need oxygen too, because you got to run fast. And so you need blood supply. So the fight or flight response typically provides increased oxygen levels. Now, certain vessels don't need, or certain extremities don't need blood. So like your peripheral vessels may vasoconstrict. That's why a lot of times when you're in stressful situations, your hands get sweaty. They may either dilate or the blood vessels may constrict depending on the stimulus that's there. And again, this is because of the surge of epinephrine in your body that generates this response mechanism. So, when stimulated, arterial smooth muscles contract, thereby constrict the artery, a process called vasoconstriction. Vasoconstriction, you need to know that definition. Or relaxation of the smooth muscles increases the diameter or lumen in a process referred to as vasodilation or vasodilatation. So, again, under the control of the sympathetic division of the autonomic nervous system. Now, parasympathetic nervous system, remember, slows you down. Mainly used in the digestive system, which we'll talk about actually in a couple of weeks. Dr. Sloan will come in and talk to you about the digestive system. But you'll see that's under primarily control of the autonomic nervous system, parasympathetic branch, but for flight or fight, we see the sympathetic nervous system is involved. Now, some concepts of blood flow dealing with vasoconstriction and the effect on the system. There are concepts that you need to appreciate, a term referred to as the afterload in the heart. This is the peripheral blood pressure of the heart that's responsible for maintaining the amount, the fluid, the volume of blood that's inside the heart after the heart contracts. Peripheral blood pressure, which you're all very probably familiar with. Those of you who are going into healthcare professions recognize the peripheral blood pressure, indication of how effective the heart is pumping to maintain the pressure throughout the system. And then capillary blood flow is essential because at the capillary level, that's where the exchange of O2 and CO2 will take place. Now, arteries are elastic. Elastic arteries are conducting arteries. These are large vesicles. I'm inside the cell again. These are the large vessels in a diameter of about 2.5 centimeters. I'm not going to ask you a number on the test. These vessels transport large volumes of blood away from the heart, pulmonary trunk, and the aorta, as well as major arterial branches of the pulmonary, common carotid, subclavian, common iliac arteries are elastic arteries. We'll show you those, or I will show you those on a slide here coming up. These are major branches off of the aorta. You will have to recognize those on your lab exam. The walls of the elastic arteries are extremely resilient because the tunica media contains a high density of elastic fibers and relatively few smooth muscles. And muscular arteries, these are the medium-sized arteries, the distribution of the arteries, they distribute blood to the body's skeletal and internal organs. Most of the vessels in the arterial system are muscular arteries. Most of the vessels in the arterial system are muscular arteries. Most of the vessels in the arterial system are muscular arteries. These arteries are characterized by thick tunica media, contain smooth muscle cells, and then the tunica media of the elastic arteries. There's our picture again. Now, again, look at the tunica media, look at the elastic fibers, look at the smooth muscle, the tunica media when we talk about the vein. Very few, you don't see any elastic fibers there. That's why these quickly collapse. You see the walls of this vessel, very collapsible. See the walls of the artery, thick layer of smooth muscle packed with elastic fibers. Again, the endothelial layer of both of these vessels, very identifiable. Should be able to recognize and label these appropriately on an exam. The external carotid arteries of the neck, part of these muscular arteries, the brachial arteries of the arm, the mesenteric arteries of the abdomen, the femoral arteries of the thigh are example of muscular arteries. There are some major pressure points. These are places in the body where muscular arteries are forced against deeper structures of bone, which will reduce blood flow when a person has severe bleeding. An example of that is the femoral artery. Pulsates, you can feel it in the groin area. If you have a major bleed in blood vessels further down, you can press on the femoral artery, press it against the bone of the hip, and hopefully restrict blood flow. If you get a major laceration or cut in the radial artery where you feel the pulse, radial artery is on the thumb side, you feel the pulse. If you get a laceration there, press on that vessel, press it against the bone that lies under it, the radius. If you press deeply on that bone, then you compress the artery, you put the pressure against the bone, you cut off the circulation of the blood. And essentially, by holding pressure at a pressure point, you can restrict the amount of blood and can save a person's life because arterial blood flow, remember, is under pressure. And so the heart's still beating. The more blood you lose, the faster the heart's going to beat. Now, that's good because the blood is sensing, oops, I'm not getting enough oxygen to the rest of the body, so I got to beat faster to get what little blood I got in my system around faster. Sounds good, however, the faster the heart beats, the faster you bleed out. And so it's a double-edged sword there. The heart doesn't know it's got a cut. All the heart knows is it doesn't have enough blood supply. So the heart beats faster. So using these pressure points is very important in trauma, emergency room, out in the field, to be able to know where you put direct pressure at. Reason why it's important for you to know where these major arteries are located at, because essentially this is important for you either to be able to detect a pulse. So you know you got to know where the radial artery is, so you know I got to ask you that on the test. You should know where the brachial artery is as it comes off the aorta, and I'll show you that in just a little bit. You should know where the carotid arteries are located at. You should know where the femoral arteries are located at. You should know where the dorsalis pedis, which is at the foot, and the, what else was I thinking about? I can't remember. Oh, and the cerebral arteries as well, though you can't feel pulses there. But these are important landmarks for you to be able to identify pulses. They're also important pressure points because they'll help you to be able to control bleeding. Arterioles considerably smaller than we see the muscular arteries. Arterioles are poorly defined, tunica externa, tunica media, and their larger arterioles consist of 1 or 2 layers of smooth muscle cells. Now, there are pressures in the systemic circuitry. The systolic pressure when the heart is beating, peak arterial pressure during ventricular systole when the heart is actively squeezing, then diastolic pressure is when the minimal arterial pressure occurs. This is when the heart is relaxing. There's pressure in the systemic circuitry, pulse pressure, which basically is the difference between the systolic pressure and the diastolic pressure. And then there is a mean arterial pressure, which is the diastolic pressure plus 1/3 of the pulse pressure. General terms that you should be familiar with: systolic pressure, diastolic pressure, pulse pressure, mean arterial pressure. Now, conditions you should know. Hypertension. Abnormally high blood pressure, typically, not always, typically blood pressure greater than 140/90. Typically. Can be a little bit different in different people. Hypotension, abnormally low blood pressure, typically with a systolic blood pressure, the top number, typically systolic less than 100, typically, but not always. Now, world-class athletes may have blood pressures of 90/40. Why? Because they're very conditioned, their heart beats really slow, doesn't have to generate a lot of pressure, and so their blood pressure may be low. Women's blood pressures tend to run lower than males' blood pressure, so it would not be unusual to find a female with a blood pressure of 90/40 and be perfectly normal. Blood pressures typically are considered low, hypotensive, symptomatic when the person has symptoms related to low blood pressure. I stand up, I fall down, I'm weak, I'm tired, I can't do anything. Symptomatic hypotension, different problem. Now, hypertension, different kind of animal. A person can have hypertension, have long-term health effects related to hypertension, but they not feel it. So hypertension is considered a silent killer because you can have a very high blood pressure and not even know it. Now, some people have high blood pressure and they may have symptoms. They may get headaches, they may get a little dizzy from it, whatever, symptomatic. They may get some warning signs, but the overwhelming majority of people have silent symptoms of hypertension. There's the elastic rebound phenomena of blood vessels, basically arterial walls. They stretch during systole. They have to. There's sheer force because when the heart beats, that blood vessel has to open up and then it recoils. Has to open up and then it has to recoil. And do that one more time. Okay, no, just kidding. Okay, they have to open up now. All right, so they have to stretch during systole, and then during diastole, you see them recoil. So it keeps the blood moving during diastole. Mean arterial pressure, pulse pressure, we already talked about. Blood pressure decreases with friction. Pulse pressure decreases due to elastic rebound. The cardiovascular center can also monitor the demands of the system. There are some particular type of receptors that are located in blood vessels that can sense pressure changes, can also sense oxygen and CO2 levels as well. There are baroreceptors. There's a baroreceptor reflex. It responds to changes in blood pressure. So you need to know that. Chemoreceptors respond to changes in chemical compositions, particularly pH and dissolved gases. What are the dissolved gases? O2, CO2. Okay, so baroreceptors respond to changes in blood pressure. Chemoreceptors respond to changes in pH. Now, this is a very intricate communication network between the blood vessel receptors, baroreceptors and chemoreceptors, the brain, and the heart. Inside the brain receives the signal from the baroreceptors that, hey, the blood pressure is low. And so that signal from the brain then tells the heart, you got to beat faster, and we're going to constrict the blood vessels. Why? Because we want to get the blood pressure up. The signal from chemoreceptors tells the heart, goes to the brain first, brain then tells the heart, hey, the oxygen level is lower, you got to beat faster. We need more oxygenated blood in the system. Now, the heart doesn't know what's going on, as the example I gave you with the laceration, where blood flow is being lost. All the heart knows is that the brain just told it to beat faster. Why? Because the oxygen level is low. Oxygen level can be low because the person's not breathing. Oxygen level can be low because it's not enough blood circulating around to give enough oxygen. So either one of those two conditions can take place, but something is sending signals. The baroreceptors sending the signal. Baroreceptors are sensing something, either low pressure or alterations in the chemical composition of the electrolytes. Now, this is a very nice illustration that you really should take some time to learn, because now I'm not twisting your arm on this, but this is homeostatic regulation. Tells you what happens inside the heart, what happens inside the blood vessels to maintain homeostasis. Normal range of the blood vessel is homeostasis. What happens when the blood pressure falls? Reflex response from the baroreceptors goes to the vasomotor center, the cardioinhibitory center, the cardioacceleratory system, increasing the heart rate, blood pressure, vasoconstriction occurs at the same time, restoring homeostasis. Okay? Reflex response of the baroreceptor stimulated, cardioacceleratory center, cardioinhibitory centers, vasomotor centers inhibited, vasodilatation, decreased cardiac output, blood pressure is reduced, homeostasis is returned. So it's an excellent illustration. There's one more illustration that I'll show you too a little later on. It helps to identify what goes on in the system. This is the baroreceptor response. Where are these receptors at? The stretch receptors or baroreceptors located in, and you need to know this, carotid sinus, aortic sinus, and right atrium. In the carotid sinus, a lot of individuals will come in with accelerated heart rates. They'll also come in with hypertension. You can do a procedure referred to as the carotid massage. And you actually will stimulate, vaguely stimulate. Remember what the vagus does? The vagus nerve is a parasympathetic nerve. Parasympathetic system does what? Slows you down. So if you stimulate the baroreceptors in the carotid artery, massage it. I don't want to massage mine too much. I'll pass out up here on you. But you can actually induce that in individuals that have rapid heart rate, sometimes in hypertension, but not always. But basically you massage the carotid arteries. It's called a carotid massage. It will stimulate the parasympathetic nervous system based upon what the baroreceptors does, and actually slows down the heart rate or decrease the blood pressure. Aortic sinuses can't get to the aorta to massage it externally. And then the right atrium, again, they monitor systemic circuitry, but the carotid artery you can actually manually stimulate by pressing a pressure point, pressing on the carotid artery against the vertebrae, the bones that are here in our neck, can depress that and stimulate a baroreceptor response, which stimulates the parasympathetic nervous system. When blood pressure rises, cardiovascular system, you get decreased cardiac output, causes peripheral vasodilatation. Very important to understand that concept. You know, you can sit and memorize this, but if you understand how the mechanism works, you'll retain this throughout your clinical careers. When blood pressure falls, cardiovascular system increases cardiac output, causes peripheral vasoconstriction. Those of you who wish to memorize that, I would do so before the next exam, because that's 2 test questions right there. Okay? So chemoreceptor reflex, Again, maintenance of homeostasis. Here's the other illustration I was telling you about. The ability for chemoreceptors to involve now not only the brain, not only the heart, but also the pulmonary system as well, the lungs. When the patient or person gets into a state that is not consistent with homeostasis, for example, a person may have increased pH. Increased pH makes them acidotic or alkaline, alkalosis. Alkalosis or acidosis? Increased pH. Alkalosis, alkalosis. So increase the pH, your alkalosis, oxygen level, you have decreased CO2. Typically your oxygen level is high, your CO2 level is low, alkalotic. So what needs to happen? You need the respiratory rate, in this particular case, needs to be, I'm sorry, I'm moving in the wrong direction. I was going to say, what does it say? It's increased up here. No, the oxygen rate actually needs to decrease in those particular areas because you want to decrease your oxygen level to maintain homeostasis. In the case of the reflex, the chemical reflex, the chemoreceptors that take place in the cardioacceleratory center, in the cardioinhibitory center, which actually sends signals back to the heart, the vasomotor center, which sends messages to the blood vessels, tells the blood vessels to constrict or dilate. You see this mechanism of maintenance, just as we saw with the baroreceptor center, sends signals either to the respiratory center and or in this case to the cardiac center, which will, in this particular case where we saw increased levels of CO2, decreased levels of O2, decreased pH representing acidosis. So what's the response for the respiratory system? You got to blow off more CO2, so the signal that's sent is to increase respirations when you have high levels of CO2, opposite of what we saw with high levels of O2 where we want to decrease the respiratory complex. You see this mechanism kicks into place to help to return and restore homeostasis. So again, baroreceptors, chemoreceptors, very important. Where are the chemoreceptors located at? You got to know this. Carotid bodies and the aortic bodies. They help to monitor the blood, the chemical makeup of the blood. Chemoreceptors below the area of the medulla oblongata, and again, I know we have not studied the brain tissue yet, but the medulla oblongata is located in the brain stem, monitors cerebral spinal fluid, also monitors and controls the respiratory function, and controls the blood flow in the brain. Chemoreceptors sense changes in pH, O2, and CO2 concentrations produced by coordinating cardiovascular and respiratory activities. In the central nervous system, the cardiovascular centers, thought process, emotional states, elevated blood pressure by cardiac stimulation and vasoconstriction. Now, there's also a hormonal regulation process in this as well. I'm just going to scratch on the surface of that because we'll go into a lot more detail in hormonal regulation when we talk about the endocrine system. Basically, hormones are produced in the endocrine system, epinephrine and norepinephrine, E for epinephrine, NE for norepinephrine, hormones produced by the adrenal medulla and the adrenal gland, which are responsible and have an effect on the cardiovascular system. There are some other hormones as well, antidiuretic hormone, angiotensin II, erythropoietin, natriuretic peptides. All of these we will go into a lot more detail in the endocrine system, the adrenal system when we talk about the hormones that are secreted there. And so I just mentioned those for completeness sake today, but we'll go into a lot more detail about what they do. The antidiuretic hormone helps elevate blood pressure. Why? Antidiuretic. What does a diuretic do? Makes you get rid of fluid. In a case where you have low blood pressure, you don't want to get rid of fluid. Why? You need the fluid inside the blood vessel to increase the blood pressure. So antidiuretic hormone, increased levels of antidiuretic hormone help to elevate the blood pressure. Does that make sense? Yes, okay. Antidiuretic hormone. So reduces water loss at the level of the kidneys. Now, if you want to reduce the blood pressure, you give the person a diuretic. Get some of the fluid out of the bloodstream. It will help decrease the blood pressure. But in the case of low blood pressure, antidiuretic hormone, high levels of antidiuretic hormone will increase blood pressure. Antidiuretic hormone responds to low blood pressure. Low blood pressure, obviously, you want to secrete more antidiuretic hormone, high plasma osmotic concentrations, and circulating angiotensin II. Angiotensin II is a chemical that increases the peripheral vasoconstriction, so it responds to a fall in blood pressure in the kidneys. The kidneys can sense the blood pressure as well. Angiotensin II is an important response to the kidneys' response to low blood pressure. So angiotensin II. There's also other chemicals inside that system. Aldosterone produces a substance that retains sodium, that retains salt. If you retain salt in the system, water follows the salt. So if you hold on to salt, then you hold on to fluid. So increased production of aldosterone can also help elevate the blood pressure. The thirst mechanism, people that go into shock, remember, blood vessels have dilated. Typically dilated blood vessels cause the blood pressure to drop, and so the thirst mechanism kicks in because you want to take in more fluid. The blood vessels need more fluid, need more volume, and so the thirst mechanism kicks in. Cardiac output and peripheral vasoconstriction all are responsible for trying to elevate the blood pressure, all an effect of angiotensin II. Erythropoietin is a substance that's produced in the kidneys. Its job is to produce or stimulate the production of red blood cells. In episodes where your blood pressure is low, you will get an increased production of erythropoietin. Again, the reason why you see production of erythropoietin is to increase the volume of red blood cells, which will hopefully increase blood pressure. Antinatriuretic hormone and brain natriuretic peptide, basically produced by cells in the atrium, produced by cells in the ventricle. Again, their ability is to increase the volume of blood. Both respond to excessive diastolic stretching, lower blood volume, lower blood pressure, and can reduce the stress on the heart. The process of arteriosclerosis, I already mentioned when we talked about cardiovascular disease. Again, it's a thickening or toughening of the endothelial layer of the blood vessel. Complications related to a number of deaths in the United States. Arteriosclerosis takes two major forms. Again, you'll see it affect arteriosclerosis can vary. Arteriosclerosis in the coronary arteries are responsible for coronary artery disease. They also, if you see coronary artery disease, person has a heart attack, there is a high probability that that individual also has cerebral vascular disease. Coronary artery disease, cerebral vascular disease, because those vessels have small lumens as well, and because those vessels are small, any type of plaque, any type of debris that builds up inside those blood vessels can lead to coronary artery disease as well. Arteriosclerosis, two major forms, focal calcification and atherosclerosis. The focal calcifications are basically a gradual degeneration of the smooth muscle, the tunica media, and subsequent deposition of calcium salts. This is a progressive condition as well. It can lead to rapid and severe calcification, which can occur in complications related to diabetes. Then atherosclerosis is associated with damage to the endothelial lining and formation of lipid deposits in the tunica media. Plaque, this is a fatty mass of tissue that projects into the lumen of the blood vessel. The plaque has relatively simple structure. Evidence suggests that the process may be reversed to a degree, may be reversed with appropriate dietary adjustments. This is a picture out of your book demonstrating that plaque formation, that fatty deposit that has developed inside the blood vessel. Now, how does a thrombus develop? Well, when you get these obstructions, platelets, which are circulating components in the bloodstream, basically will begin to attach to these fibers that are projecting into the lumen. As the platelets adhere and aggregate, it leads to the formation of a localized blood clot that will further restrict blood flow through the artery. What's the best approach for plaque? Well, you can read the following: reduce the amount of dietary cholesterol, stop smoking if you smoke, check your blood pressure when you're taking steps that are necessary, having your blood cholesterol checked regularly, controlling your weight, and exercising regularly. Okay? An aneurysm typically is a weakening in the vessel wall. Arteries that carry blood under great pressure, such as the aorta, where the walls in the arteries are adapted to handling this pressure, sometimes can undergo compromise. Occasionally, local arterial pressures exceed the capacity of the elastic component of the tunics, tunica media, tunica adventitia, tunica externa, and produce an aneurysm or a bulge in the weakened wall of the artery. The bulge resembles a bubble in the wall, like a boot in a tire. We used to call it a boot in a tire. Now they have tires without inner tubes, so you don't really get that concept anymore. But it's affected by arteries. You can suffer a catastrophic blowout. I do a continuing education course on aneurysms where we talk about signs and symptoms of aneurysms, how they can present with varying signs and symptoms. If I give that during the course, I'll let you know. But basically, it's a weakening in the vessel of the wall. That weakening can allow either blood to fill up in the intimal layers of the vessel along the tunica media, so blood can leak between the vessel, and actually a dissecting aneurysm is when blood starts to fill inside the layers, inside the walls of the blood vessel. And literally, that dissection can extend down the entire length of, say, the aorta or the blood vessel that's involved. Now, you can also get a weakening in all of the walls of the blood vessel. The blood vessel will dilate and get big, but you can get a dissecting aneurysm, which basically means the tunica intima and the tunica media separate, and the separation is caused by blood filling into the two layers, and will separate and will also balloon out and cause a problem. If they rupture, typically it would be fatal within minutes. Again, that's a high pressure system. Tremendous amounts of blood are lost in short periods of time. Typically the two are related. Aneurysms occur in individuals that have arthrosclerosis. Now, it's not an absolute, but you certainly see a correlation between aneurysms and arteriosclerosis. Aneurysms can also be associated with conditions such that would weaken the wall, such as inflammatory processes. Marfan syndrome, you may have heard of before. It's a hereditary disorder, causes weakening, difficulty maintaining connective tissue structures. Hypertension and aneurysms, also closely related. Unfortunately, again, because blood pressure can be a silent killer, many times the blood pressure goes unnoticed, causing a significant amount of stress on the blood vessel, leading to problems. Capillaries, important vessel, important because the endothelial lining is very thin. Typically, there's only one layer of cells. There are also small pores in the capillaries, which allow windows to create it. They're fenestrated, or they have little tiny windows that will allow the diffusion to take place in the system. The capillaries do the real work of the cardiovascular system. It's done in microscopic capillaries that permeate most tissue. These delicate vessels weave through active tissue, forming intricate network that surround muscle fibers and radiate through connective tissue muscles, radiate through connective tissue, branches beneath the basal lamina of epithelium. Capillaries are the only blood vessels whose walls are thin enough to permit exchange between blood and the surrounding interstitial tissue. Maybe I should say that one more time. Capillaries are the only blood vessels, capillaries, not the aorta, not branches off the aorta, not the superior vena cava, not the inferior vena cava, not the brachial artery, only capillaries. Capillaries are the only blood vessels whose wall permits exchange between blood and surrounding interstitial tissue. Importance: capillaries are the only blood vessel whose wall permit exchange between the blood and the surrounding interstitial fluid. This is an illustration out of your book demonstrating capillary network. As you can see, the free exchange between arterioles and venules and the importance of the exchange that takes place. These are also in close communication with the end organ tissue that's associated with this, and so through a process of diffusion exchange through the fenestrated windows of the capillaries, it allows exchange to take place. Capillary beds do not function as individual units, but as a part of an interconnected network of a capillary bed or capillary plexus. There can be anastomosis. Anastomosis are connections, direct connections between arterioles and venules. When arterial venous anastomosis is dilated, blood will bypass the capillary bed and flow directly into the venous circulation. The pattern of flow is important. and these anastomosis, and it's regulated primarily by, and we saw this again, the sympathetic innervation of the autonomic nervous system under the control of cardiovascular center and the medulla oblongata. Veins collect blood from all vessels, tissue, organs. The walls of the blood vessels are thinner than those corresponding with the arteries, and the venous walls need not be thick like the arterial walls because they are not under the pressure of the arteries. Now you saw the thick muscle layers of the artery because it's under a lot of shear force. When the heart beats, that vessel has to dilate and then it recoils and constricts. Dilates and then constricts because of the elastic fibers. Veins don't do that. They don't receive that force from the heart. They receive their blood flow from the capillaries. That's the highest point of pressure for the veins, is when the arterioles communicate with the capillaries. After that point, it's not under very much pressure, and blood through a passive process gets back to the heart. So it's not under pressure. So the venous walls don't have to be thick like we see in the arterial walls. Veins classified according to size, just as we saw with the arteries. Venules, medium-sized veins. Again, you don't have to worry about the numbers. And the large veins, which include superior, inferior vena cava. Oh, one more point. There is tunicle layers that are represented in the large vessels. Blood pressure in venules and medium-sized veins is so low that it cannot oppose the force of gravity. So in structures such as the legs, they're valves. Now I said before, veins have valves. When you move the calf muscles in the legs, it pumps the blood up the system, opens up the valves. With pressure, the valves will close down so blood doesn't back up. Now if the valves get damaged, and valves and veins can get damaged, people who stand a lot, like in the teaching profession, people who work in a hospital setting on hard floors, who walk up and down the hallways, sounds like a nurse, because you stand a lot, the valves in your legs will eventually get weak. And because they get weak, they'll eventually just flop down. Remember, these aren't very strong vessels. Then blood will start to accumulate or pool in those veins. That's called varicose veins. Other things that can damage the veins. Pregnancy. Pregnancy puts pressure on the inferior vena cava. You put pressure on the inferior vena cava, now this passive process by which the calf muscles in your legs help pump the blood back up to the heart can't overcome the resistance caused from a 8-pound baby, 7-pound baby, okay, I'll be generous, 7-pound baby, because it puts pressure on the inferior vena cava, it causes varicose veins. So pregnancy can damage the valves, and the valves, it's the damage of the valves that allows blood to settle and to sit in the veins. Now, varicose veins, what do? You basically either can clip the veins out, you can inject a substance that will scar the vein up. If you scar the vein up and blood can't get into the vein, then you get rid of the varicose veins. Now, you can cut out varicose veins because you got so many veins in your legs, you got more veins than you'll ever need. But it's a process that can occur, again, because there are valves there, and if the valvular system of these vessels become damaged, then it can lead to major problems. Venous compression was what caused the contraction of skeletal muscles. That's it. Now, what's the pump in the leg? The pump in the leg is, what's this muscle? What is it? Somebody said it. Gastrocnemius muscle. Gastrocnemius. Was that you up there, Tiffany, said that? Shout it out. You knew that. Gastrocnemius muscle. That's the pump of the legs. You don't see men get varicose veins much. I'm not being sexist here. Men have more developed skeletal muscles. Why? Because we got a hormone, testosterone, that makes muscles develop a little more aggressively in men than in women. And so men have big gastrocnemius muscles, so in essence, men don't develop varicose veins. Women don't have big gastrocnemius unless they work out a lot and they exercise that particular muscle. If you have a great gastrocnemius muscle, then you really stand a lower chance. You still, in women, you still got to deal with pregnancy if you plan to have children. You still got to overcome that. But if you have a greatly developed gastrocnemius muscle, you don't get varicose veins. So a lot of women that run or that do calf exercises specifically, they increase the pump in the leg. You can see and appreciate, I may put this picture on the test, you can appreciate this is a valve. So if I ask you to identify that structure, that's a valve. It's in a vein. This is the gastrocnemius muscle that's responsible for pumping blood out of the lower extremities. Gastrocnemius muscle. Varicose veins, I already talked about in that process, and cardiovascular hemorrhaging. Now this is another great picture, and I know you guys are not going to learn this one, but that's just a great illustration. Let me do one thing for you real quick, and then I'll let you go. Well, I mean, you can go anyway, but I mean, so I'm going to come back when we